So good afternoon, ladies and gentlemen. I have to apologise to start with because pathology does not have the infrastructure that radiology has. Radiology has been digitised because they could afford it, because they got rid of their development of films. We don't have that luxury, so we do not have a digital pathology backbone for the NHS, and that will take huge investment. So if we're going to use these technologies, we need a major investment, which at the moment is not planned. So you have to bear that in mind. Now, you can't work in this field without industrial contacts, I'm afraid, so there's a range of those. I don't believe it will skew what I tell you. I'm going to give you an honest opinion, basically, I'm employed by the university and the NHS, and I will give you that view. So this is what I'm going to talk about. Creating better patient care, bit of history of AI, beware the promises, digital pathology, because without that, it doesn't work. Where are we at the moment? Then a bit about hemotoxin and eosin, which, can AI get rid of the pathologist? Competing technologies, which you always have to take into account. And then AI generates more data. We've got to turn it into wisdom. How might we do that? What might the future hold? So we want to create better patient care, and this is based upon the knowledge pyramid, that the pathologists can generate data. We can generate loads of it, same as the radiologists and a whole bunch of other people. We've got to turn this data into information, the know what, then the know-how, the knowledge, and then actually the only thing that matters at the end of the day is the wisdom. What do we do to the patient? Do we treat them or don't we treat them, or the decision part of the process? And the only point of having data is to get to that position. And one of the aspects which isn't considered is that we're going to have algorithms at the data level, but we also need algorithms all the way up that knowledge pyramid to generate that wisdom. So it's not just going to be about simply data algorithms. Now, artificial intelligence goes all the way back to ancient Greece with the first algorithms. Artificial intelligence as a term, I believe, if you believe Wikipedia, was termed in 1954. That was I wasn't around then. That's my parents getting married. And it's been through various cycles. And this is the standard technology cycle that you'll all know very well. The peak of inflated expectations, are we there at the moment? The trough of disillusionment, and then the plateau of productivity. Now, they've had AI winters, and we've had several of these over the period. What's happening in 2019? These are the young academics in Leeds, and we think that there is now a better opportunity. But the problem is we've been through hype. I'm long enough in the tooth that I've seen a lot of hype, and you always have to bear in mind this hype. So we've had RNA profiles, lots and lots of algorithms developed there, overfitting on 30,000 variables, and they do not validate. Out of those, of course, came the spin-out companies. So Oncotype DX, Agendia, Almac, and they raised very large amounts of money on the New York Stock Exchange, 100 million for Oncotype, 65 million for Agendia. Well, they are hopeless and valueless tests in bowel cancer. And we've just been through one with Almac, and it validated the opposite way. So be very careful about the spin, especially the company spin, in selling you these products. And we have the same risks. Here are a whole bunch of potential PT1 cancers. We have the same risks of overfitting the data, and we have to be very careful about the claims that are being made. Algorithms. You'll be sick of algorithms over the next 10 years. So in cardiovascular disease, I'm a bowel pathologist, and I'll use bowel examples. Cardiovascular disease, you have over 1,000 algorithms, and yet in day-to-day practice, you use very few. Why do you use very few? Because you don't know which one's the best. And actually, sometimes you just are being totally overwhelmed by these sorts of things. And being long in the tooth is quite useful because it's taught me to start out with the end in sight. If I want to develop a new test, I need to know where's it going to end up, what am I going to validate it on, because for all of these algorithm generations and the AI, we need to have the validation. And if you don't have the validation, there is no point in starting. We've been generating validation data sets. We've got over 30 clinical trials in bowel cancer where we scanned all the slides of those trials. And so we've been developing these data sets because we believe that they're going to be fundamentally important, especially associated with high-quality clinical information and what happened to those patients. And also, We're working within the Yorkshire region and within N6, the northern major university cancer centres, in order to generate the data that will enable us to ultimately validate some of these things. But it takes a lot of time and it takes a lot of digitisation. So pathology and digital pathology has been around a long time. So I was born in 1955 when they made those first digital images of cervical cytology. Are we using cervical cytology AI algorithms in 2019? No, we're not. We did get involved in the 1990s doing a big project with a commercial cytology analyzer, but it wasn't good enough for the NHS. But I first got introduced to digital pathology when I visited NIH, a guy called Stephen Hewitt, in 2002, and I saw the first ever Apereo digital scanner. And I was lucky enough to get the money in 2003 to get one in Leeds. And then we were very lucky to employ Darren Trainer as a young academic pathologist many years ago. Darren then did his PhD, and by 2008 we had 6 scanners in the department, and Darren has gone on to do a whole bunch of work on ergonomics of digital pathology, the validation of it, 3-dimensional digital pathology. We've been working on the clinical trials, and we've got education type aspects. And then this has led to the creation and validation and licensing from Leeds to Roche of an ergonomically effective workstation. I have no money from that licensing deal, but it is ergonomically equivalent in terms of the microscope and the workstation. That's the first time ever. Developed Powerwalls, which are these fantastic digital pathology platforms for teaching, and the University of Leeds spun off with Heterogeneous. And again, I have no investment or commercial relationships there. Where are we in 2019? Well, Leica are doing an LTHT, the Leeds Teaching Hospitals Trust, complete digitisation. Innovate UK have funded us with multiple companies to try and look at digital pathology and artificial intelligence, and we've just been awarded a UKRI Artificial Intelligence Doctoral Centre. So things are looking interesting, and this is the digital pathology website if you want to visit it at some stage. So the practical view about where digital pathology is at the moment is that it's in the phase of augmentation of what we can do. And it's very helpful as long as you have the digitized slides, that is. We can quantitate, we can do size, area, we can look at individual components, we can do lymphocytes. Here are lymphocytes being identified automatically, and we can do stroma and 3D modeling. Immunocytochemistry can be quantitated via these techniques. We can do image analysis, it can be done on multiple antibodies, and we can do immune profiles. So there's a lot we can do in 2019 as long as you have those digitized images. But where we go next is the H&E algorithms created by those technologies you've just been taught about, and I'm not going to repeat that stuff, and hopefully new data science techniques to enable us to move further forward. But what is our future? Is it the replacement of the pathologist or the augmentation? Hopefully I believe it's the augmentation, but I might be a dodo here, who knows? One of the big questions is actually, what's our future? If it is our replacement, then pathologists must evolve into wisdom doctors. These are the doctors that can take the data, the knowledge, and turn it into the wisdom to be able to give it to other people. So we may see a major transformation of our roles, but I don't think that we're going to be dead and of no value to society as pathologists. So I still do encourage my younger colleagues to come and join the fun. So this is what we do, histopathology. You have here a PT1 cancer, and you have here a lesion which looks very, very similar to a PT1 cancer, but actually this patient doesn't need an operation. They've had a perfectly good operation here, and they don't need to have their rectum removed physically from the body. So the difficulty is, can this be done artificially? Now, there's more of a problem with pathology because we have a lot more scale. So radiologists have less scale, so we go from the macroscopic all the way down to submicroscopic resolution these days. We have color issues and color variation. We have context of cells. We have the relationships between those cells, and then we have various patterns to take into account. We also generally have multiple samples, so you've got to be able to look at all of the samples, and sometimes that can be 50, 60, 100 slides, and then you'll take multiple sections. So you may end up on some unusual cases with 400 or 500 slides. These all have to be scanned, they all have to be interrogated potentially. But the hope is that we will get, well, they'll be able to use the known features to derive algorithms, but also with machine learning, we will have the unknown factors that we as pathologists have never ever noticed. And there is a lot more information in those phenotypes, in those H&Es than we have ever imagined. And if that's the case, and we can extract those, then it may be that machine learning and artificial intelligence will be really fantastic for our ability to improve patient care. But we have some big problems. Firstly, we're not digitized across the entire NHS. That's a pretty big problem. Secondly, machine variability. We have a load of different platforms, and they all have different scanning properties. So how does that affect your algorithm when you're training it? And we have no DICOM standard. If we don't have a DICOM standard, then any algorithm that's developed is going to be dependent upon that machine. And if we have 20 different types of manufacture at the moment, how's that going to be used around the nation? We need a DICOM standard, and that's one of the things that Innovate have funded us towards trying to help achieve. So, some examples of what we can do today. Here's simple measurements. These are simple measurements of the distance extramural spread of a tumour, and that's a significantly important prognostic factor in helping us to decide whether to give them chemotherapy. Here are the lymph nodes. We can quantitate the involved lymph nodes and the uninvolved lymph nodes, and what you see is that the involved lymph nodes, many of them overlap. So this immediately tells us that the radiologists can't use size to determine whether a lymph node is involved or not, as they have been doing in the past for a long time. We have the ability to put arrows on to say, are they landing on tumour cells or are they landing on other parts of the tissue? This has turned out to be really quite interesting. These are different clinical trials, and this is the median tumour cell density. How many tumour cells have you got per unit area? This is a standard untreated trial of laparoscopic versus open surgery, but these are different types of chemoradiotherapy. And what they show is that very early on in a trial, we can probably tell which of the treatments are working best just by simply quantitating the number of residual tumour cells. And we hope to be able to take this further on to have early indicators in phase 1 trials. Very simple methods such as that might be quite useful. Interestingly, stroma, tumour microenvironment, but the amount of stroma you have in your tumours actually looks, so this is a high stroma, this is a low stroma. You can again count it by whether it falls, that the arrows fall on stroma and not on tumour cells. And this is quasar, major, stage 2, stage 3, early stage 3, colorectal cancer trial, which shows that actually, if you can only quantitate the stroma, you can identify a group, these are the very high stromals, that have double the recurrence rate, and therefore definitely should have chemotherapy. So simple stromal counting and simple tumour cell densities can actually give us valuable information. This is very simple and not even AI type work. Now, Alex Wright in the lab has been taking all of those annotated areas, and so we've generated the annotations on over 1,800 tumours, and has been taking it through AI processes, much of it with image processing here, and can actually get automatically those stromal ratios with an accuracy of over 80% at the moment. And 80% actually may be enough for this sort of situation because the tolerances within the system are so good. Tumour budding, another fact that we as pathologists don't like to do. This is definitely prognostic. Again, it's prognostic in this quasar study, over 1,800 patients done there. And this is the number of individual tumour cells you have. It's also prognostic in the very early stage tumours where we're making a decision about major resection or not, and that can help. The problem of budding that we used to have internationally was we all used different methods, but now we've managed to get an international consensus, and lo and behold, we have our first papers showing automatic budding measurements. So we can do stroma, we can do tumour cell density, we can do budding. So they're coming along. And there's other characteristics here. We can do automatic tumour detection, lymphocyte counting, and the immunohistochemistry quantitation programs are coming along nicely. This is a commercial platform. It's Roche. They happen to be one of our funders, and we're validating Roche's CD3, CD8 in the N6. And this is Darren's platform on the Roche system. So one of the challenges for the future, which is really quite interesting, is we have the commercial development of all these programs to be sold to us. But actually, we also have free software. There's Halo software and others out there. And should we, as the NHS, the commercial funders will kill me for saying this, should we, as the NHS, be developing our platforms that we can use within the institutions rather than necessarily having to use commercial ones? But at the moment, we have to use the commercial ones because we don't have those large banks of free software. But I think we should have. So this is the CD3, CD8. It takes a bit of interaction with the pathologist outlining the tumour, but then there's some machine learning here, and it's looking at the CD3, CD8 ratios, and this is the first series in Leeds. There's another series in Australia which shows exactly the same, and we'll be taking this out to validate on a much larger set of H&Es coming out of those northern cancer centres. So this is an AI-based system, and it's here and now, and will be commercially available. But with digital pathology, we can do a whole bunch of other things. So we can get over the colour issues. So here is a bunch of liver biopsies. They're all different liver biopsies. Derek McGee in Leeds has managed to develop a program which actually restains them all electronically, so we can get rid of the staining problem for AI. We can create 3D data sets now and cut through tissues and look at the pathology of that. And here is an annotated image of the vasculature within the bowel. And we can even integrate radiology and pathology now. Derek McGee's developed a program so we can actually look at helping our radiology colleagues in getting better at what they do, and they might help us to get better at what we do. We have stuck. Oh, no, hang on, I have to go back. Okay. Hang on, right, here we go. Right, so, but the big question is H&Es. Will it add value or will it replace us? Because you can just see by looking at this that there are a wide range of images here, and will AI be able to pick out in this series of potential PT1 cancers what's going on better than the pathologists? You have to bear in mind that as pathologists, we only look at samples of tissue, and this is a bowel cancer here, and if we say the volume of the bowel cancer is 1, and this is a liver, and say that that's the volume of that liver, if we look at a section, a single section from a bowel cancer, we're looking at 1/37,000th of the volume, and here in a liver, 1/750,000th of the volume. And if you just take a single TMA core, which we do in multiple studies, then you're looking at 1/37 millionth of the tissue, and here 1 in 750 million. So really, the pathologists are sampling very little tissues, so we have the issues of heterogeneity of disease, which we can get over with targeted sampling or modified sampling. But again, the AI has to take this into account, and it may not be able to diagnose very effectively some of these diseases because you may not have enough information there. But we know we can datafication. I don't really like that term. You can datify a slide all the way through. Now, these are in existence, and deep learning algorithms, image recognition, soft learning, statistical learning, lots of different methodologies. But actually, you can go from a slide to a data point. And the question is ultimately what that data point means. You can create these very beautifully annotated slides automatically, but we don't know what its capability is. We don't know how it compares with the gold standard, which, of course, at the moment is a pathologist. Do we see overfitting of these machine learning models, as we've seen for RNA? And does it recognize artifact effectively enough to make it give us the right diagnosis rather than the wrong diagnosis? All these remain to be answered. And then, actually, it's really not just about the H&E. We've now got some fantastic new technologies which you have to take into account if you're going to put your money on the horse that's going to win in 10 years' time. So this is the Vectra, comes from PerkinElmer, and they can do 9 antibodies on the same slide. At the CR UK Grand Challenge earlier, a month ago, we saw this. This is a Codex 2. That's a piece of tissue that's been stained simultaneously with 41 antibodies. And I know that you can do 105. And in speaking to the man who's developed it, he can do 140 in his lab. So you end up with this ability to intensely interrogate a piece of tissue, and that definitely needs machine learning, segmentation, unsupervised clustering, phenotype mapping. But this will undoubtedly tell us enormous amounts. But it, again, all has to be put into play against the H&E and the machine learning. But we also have other kids on the block, so mass spectrometry, tissue imaging, and here you get vast numbers of points, vast amounts of data, and you have to data mine it. How much more information, well, wisdom is in here versus those other technologies. This is nanostring. Nanostring, you can now barcode DNA, RNA, and protein. So we're not either DNA people, RNA people, or protein people. We're basically coming back to be together, because on this platform, you can analyze the whole pathways. So again, there's lots of competitive technologies to just the machine learning of H&Es. So the amount of data, so here for bowel cancer, these are many of the bits of data that we need. So patient factors, multidisciplinary team factors, how good are they performing, our histopathology ones, our molecular factors, and our immunological factors. With AI, we're going to massively increase these histopathological amounts of data, and we're also going to increase the molecular factors and the immunology factors, but it's all still data. We need to generate the wisdom, and we need to generate those algorithms to provide that integration of data. And so I'll show you some of the things we're doing in Yorkshire to try and plan for this and to try and get some answers in the future. So we've got our NPIC, so we'll be doing the AI, and that will be including immunological profiling. We've got links through to UK Biobank and 100,000 genomes that are being actively discussed. And, of course, we'll be putting in additional data here with patient factors and multidisciplinary team factors. What we're collecting through Eva Morris is that we now have information on all the bowel cancers in Yorkshire, age, sex, deprivation, comorbidity, and patient-reported outcome measures. You know, how did they feel about what we did to them? And there are 15 hospitals there, all in Yorkshire, and this is the data over the different years. And so we have all this data. On top of that, we also have performance data. What did they do to these patients? So the type of surgery, the pathology data sets, the radiotherapy, who got radiotherapy, who got chemotherapy. Because if we're going to get to wisdom, we've got to integrate all of these data sets in order to know the value of the data that we're generating with our AI here versus all the other bits of data, because there's just loads of data, and it's the wisdom we need to get to. So ultimately, we need algorithms not only within the histopathological factors and the molecular factors, but also to be able to absorb and work out what is going on with these. And we need to generate these sorts of personalized prognosis packages. This is one from Memorial Sloan Kettering, which is relatively basic, but we hope to be able to add in Yorkshire data and national data through EVA's CRUK program in order to generate this sort of wisdom for managing these patients. So we've been helped by Innovate UK, and we have an imaging centre, there's one in London, one in Glasgow, one in Oxford. Here's us, and here's Coventry. This is what we've said we're going to do, and we have every intention of doing it. Deploy digital pathology for primary diagnosis in 2 complementary applications. Darren is doing a primary diagnosis in a large NHS network, that's our own teaching hospital, and 6 other hospitals to generate all those H&Es so they can be used for machine learning. We're doing the precision medicine in the 6 northern universities, Sheffield, Liverpool, Manchester, Nottingham, Newcastle and Leeds, and then developing the infrastructure to collect the image data, create standards and processes for sharing the data, establish best practice, quality assurance, and influence of adoption. So a lot of stuff to do, but other people will be doing a lot of stuff as well. But we have to thank Innovate UK for this investment. So the messages are, pathology has never been more exciting. AI will be positive for pathologists, I believe that. It's already here in a number of settings, a number of obstacles to be resolved. Firstly, digitization of the NHS. Will it happen? If it doesn't happen, we can't apply it at scale. DICOM standards, absolutely. Scanner variation, absolutely. These must be resolved. The algorithms are generated are only as good as their validation, and we need to know how good they are against the gold standard, so we need to know which ones to use. The technology is also rapidly advancing. There are other competitive technologies. Which ones should we be using? And AI is going to be used at multiple levels, from just the looking at the data to actually looking at all the sorts of data and how we get to integrate that with the patient data and the value ultimately it is to the people making the decisions, because that's the only thing that matters. So I must thank YCR, Innovate UK, lots of other funders, the digital team, especially Darren here and Alex, the science team, the data analytics team, Eva Morris, who we couldn't do any of this without, and the team says thank you. And what I'm hoping is that in the future, this is what will happen in the clinic. I'm referring you to the pathologist, or it may be the data doctor. That's what we're going to be. And if anybody wants to know more about all the wonderful things in pathology, Leeds Pathology is on in the summer, and you're very welcome to come and see us. Thank you very much.